to talk about biopsychosocial models. And I'm going to focus primarily on neurology, talking about biopsychosocial models in the Neuro ICU, and then transition to outpatient specialty clinics. But you can really apply everything we're going to talk about today to any type of disease or any type of department where you may want to transition toward a biopsychosocial model of care. So let's see. So I have no relevant financial relationships, but the work that I'm presenting today has been funded by the National Institute of Nursing Research, National Institute of Aging, NCCIH, and American Heart Association. So today we are going to review the importance of a biopsychosocial approach to the care of neurological patients and families. We are going to describe the patient with an acute neurological illness as well as their caregivers. We are going to understand the process of co-developing a biopsychosocial intervention using the NIH stage model in the Neuro ICU, as well as applications of this model to developing interventions for outpatient neurological illness. And we are going to discuss the development of a clinical research and training model for biopsychosocial care in the Neuro ICU and applications to outpatient neurological illnesses. So why a biopsychosocial approach? So I don't know all the disciplines folks are coming from here and where sort of folks are sitting on this sort of biopsychosocial approach. But I thought I'd give a bit of a background. So the biomedical model was introduced more than a century ago, and it was introduced by Louis Pasteur's germ theory, which talked about the fact that a disease is the product of a biological defect. And then consistent with this model, once the biological defect is identified and treated, the disease is supposed to be cured. So if a biological defect is not identified or a treatment does not work, then the condition is caused to be mental or psychological or psychosomatic. And this biomedical model was hugely successful at the beginning of the century, leading to decrease in or elimination of many infectious diseases and really saving many lives. However, the biomedical model does not really work outside of infectious diseases. So we don't have an antibiotic for, cancer, dementia, or for the majority of neurological illnesses. It would be nice if we had, but we just don't. So as a result, the biopsychosocial model was introduced by Engel in about 1977 to describe that the illness experience is a function of biology or disease, but also the psychological or behavioral factors. So things like coping, illness appraisal, mental health, as well as social factors such as social support and social determinants of health. And then over time, the model evolved so that it now includes spirituality, which we know is extremely important in the context of neurological illness. So what this model shows is that people with the same level of disease can have different trajectories based on the interrelation of the biopsychosocial factors. And in 2007, Schroeder published a study in New England Journal of Medicine supporting this biopsychosocial model and showing that health is a function of not only genetics, but also a large percent of variance in health is determined by behavioral factors, by psychosocial factors, which are modifiable. However, the current model of care for neurological illness continues to be primarily biomedical. The focus continues to be on identifying the biology and treating it. And most of the time, referrals for psychosocial services happen much later in the course of disease or sometimes never. And that's a missed opportunity because employing a biopsychosocial approach to the care of neurological illness or any type of illness from diagnosis to end of life, it's really an important opportunity to optimize recovery when recovery is possible, support patients and caregivers with building and maintaining resiliency skills so that patients can live well and sometimes die well if it's a terminal disease, and caregivers can also adjust and maintain their well-being. So I'm going to spend some time discussing the process of developing a biopsychosocial model of care in the Neuro ICU at the Massachusetts General Hospital. And I'm going to start with the impetus of this work, which is a couple named Laura and William. In 2015, I met a neurologist at Mass General, who at the time was the chief of the Neuro ICU. And he shared with me that many patients in the Neuro ICU made very good physical recovery, but were readmitted to the ICU, and that many times families talked about intense emotional distress. And he noted that these patients and families were very challenging for the staff to treat because they felt very unprepared. And a few months after meeting this neurologist, I accepted a consult in the Neuro ICU and met this couple, William and Laura. So William was a 53-year-old male who had a stroke. Per family report, he had a history of untreated anxiety, and he never wanted to talk about his anxiety. In the ICU, he presented as very anxious, and he was also non-adherent, and was a bit of a problem for the staff. I also met his wife, Laura, who was 52 years old. They had been married for 20 years. They had three grown kids. One was expecting his first child. And Laura was described by the nursing staff as very worried, a bit overbearing, and unable to leave William's bedside. The children were also worried, and the staff was overwhelmed and could not keep up. So this is sort of a picture of this couple, but it's a typical picture of what you can see in the Neuro ICU. So, as part of the assessment, I administered measures of depression, anxiety, and post-traumatic stress symptoms. So you can see here that William endorsed clinically significant symptoms of anxiety in the severe category, depression in the moderate category, and his post-traumatic symptoms were mild. This was also consistent with his presentation. And Laura endorsed no symptoms of anxiety and depression and very mild symptoms of post-traumatic stress disorder, which was really not consistent with how the staff was describing her. Um, so, um, my conversation with William and Laura showed that William was confused, was frustrated about why the stroke happened. He expressed many worries about the stroke recurrence, about being a burden on his family, about not being able to help his son with his new baby. He had taken care of his parents and did not want this for his wife and family. Again, didn't want to be a burden. His wife, on the other hand, described herself as strong under pressure. Again, verbally denied any distress and had limited insight into how she was coming across with the nursing team. She did know that she could not sleep or exercise or use social support, things that she knew were very important for her mental health. And she looked very anxious to me. And the stroke also impacted the couple's interpersonal relationship. So there were disagreements between the two of them, as well as the larger family, in terms of how the stroke should be managed and what should happen post-discharge. So there was a lot of frustration that was impacting the relationship between the couple as well as with the extended family. So, a case like William and Laura is common in the ICU, and per the sort of usual model of care, what would happen in this situation is that a psychiatric or social work consult would be started. There wouldn't be really any sort of formal assessment of emotional distress for the patient or the caregiver. There wouldn't really be formal treatment for emotional distress. Maybe there would be a sort of a prescription of SSRIs. There will be consults, again, 1 to 2 brief sessions, and maybe referrals after discharge. There wouldn't be any follow-up after discharge, so we wouldn't know if the couple would follow up with any sort of mental health care. No continuity of care post Neuro ICU stay. And really, when we think about the Neuro ICU, the goal is survivorship and discharge. So the neurologists I talk to, they say, if the patient gets discharged, they don't die, like that's the win. And while this model was really great in the past. Now more and more people survive, so we really have to think about how they survive and what happens to them after discharge. So, obviously, there are challenges with this model of care. Um, we started to do some research. So, we conducted several studies which showed that about 40% of patients and caregivers experience clinically significant anxiety, about 20 to 30% experience depression, and about 15 to 20% experience post-traumatic stress symptoms. And if untreated, these symptoms impact the recovery trajectory, increase readmission, and increase risk of death. And within the current model of care, we're really missing this important opportunity to positively impact the recovery trajectories of patients and prevent negative health sequelae in both patients and caregivers. So a lot of the sort of work that we started to do was to try to shift this model of care from biomedical to biopsychosocial, where it's not enough for patients and families to survive. We want them to adjust well to post-discharge and continue to maintain good quality of life. So how might we transition to a biopsychosocial model? So these are some of the things that we've done. So first, it's important to develop a compelling vision and secure buy-in from leadership and staff on the unit. And that has to do with building relationships. So for us, I had buy-in from the chief, who really, was the one who kind of brought me on the team. But I really needed to build relationship with the nursing team and the social work to really understand their perceptions and needs, right? So I was a guest on their unit, and I really needed to make sure that they felt good about, me and the team coming on, and that I was an add-on, and everything that we were doing was building on what they were doing and was meant to help. Um, Second, it's important to understand the nuance, to develop a nuanced understanding of the problem we are trying to solve. So for us here, we needed to understand a little bit more about the psychosocial distress in the Neuro ICU, including perceptions of patients and families. So we knew there's the stress at the time of admission, but we didn't know what was happening with this distress over time. Would it go away? Would it not go away? Would patients and families want an intervention or not? So there was a lot of work that we needed to do. We also needed funding to do this work, um, and we really needed to think about developing a solution that's sustainable. So, just like when we're doing community work, community engaged work in communities, and we don't want to just go do the research and leave. Same here. I look at the research and medical departments as being sort of a community engaged type research where we wanted to get feedback, we wanted to develop something, and then we wanted to think about how can we sustain this when the money and the funding is gone. And you see here a lot, build relationships. That is really the key. Really understanding the culture, respecting the roles and expertise of all providers who are involved, and just really checking in at every step, to make sure that, we're not on the way and that we're building something that everyone is feeling part of, and we're all unified with the goal of making things easier for patients and families. So I was fortunate, as I mentioned, to have great buy-in from the chief of the Neuro ICU. So I really started focusing on building relationships with the nursing staff. So I started attending weekly meetings with the nursing staff. And this was to learn about the unit, but also to learn about their lives, to learn about what it's like to be a nurse in the ICU. So, I learned about how stressful their work is. And at some point, we started a mindfulness group to decrease stress in nurses, even though we didn't have funding for this. But also, starting to learn about them as people, learn about their kids and, learn about their sort of struggles and really developing sort of a genuine friendship. Started to attend huddles, rounds, schedule weekly meetings to discuss clinical cases, monthly meetings with the chief of the Neuro ICU. I was able to negotiate for some seed funding from neurology for about 20% effort for a clinical psychologist to provide clinical care and kind of, sort of try out different approaches that might work with these specific populations. We also got some seed funding to pay for a research assistant and had some 10% work for a psychologist for research for 1 year to really start deepening our understanding of the patient populations and really conducting some prospective work to try to understand the trajectory of emotional distress and think about psychosocial treatment targets. We also developed a rotation for psychology fellows to provide clinical work and engage in research, and also starting engaging the neurocritical care fellows, so that we can, do some sort of cross-pollination of knowledge. And this was, again, very attractive to the Neuro ICU as well, which helped us with more resources. Really from the beginning, we wanted to focus on combining clinical work, research, and training. And again, that was very attractive. We're at MGH, we're a teaching hospital, and that ended up working really well. So when we looked for any interventions that had some level of efficacy in this population, we were able to find only 3 large clinical trials that had been conducted, including a large multi-site trial that had been conducted in the UK, and they were all negative. And so they all had methodological limitations. So there was a lot of confounds, a lot of stress to internal threats to internal validity. And so we really knew that we needed to develop and implement the psychosocial interventions since none had efficacy for that population to begin with. And so we wanted to be very rigorous. And so we used the NIH stage model and the science of behavioral change to guide this work. So this model may be familiar to you. I'm just going to sort of describe it pretty quickly. So the model provides specific guidelines for the steps that one needs to take from an idea to an intervention that is implementable to maximize potency and implementability. And so it has 5 stages, and I like to think of it as kind of a GPS. You just kind of plug in the address, which is for me is like implement the intervention, and then it can kind of tells you where to go. And you have multiple ways of going there, and these are the arrows that you see going from different stages. So you don't necessarily have to go to stage 0, 1, 2, 3, 4, 5. You can go back and forth if you have to make modifications. And then we also use the science of behavioral change guidelines for identifying mechanisms for interventions as well as measuring them appropriately. If you don't know of the science of behavioral change, definitely Google them. They have a lot of really cool information that's very useful in the process of intervention development. Okay, so we studied in stage 0, and we really wanted to understand whether emotional distress in the ICU maintains, worsens, or goes away. And we wanted to understand how to identify the patients who are most in need for a psychosocial intervention so that they would be prioritizing research and treatment, right? So not everyone experiences emotional distress. Some people do well. And so we really wanted to focus only on those who need us. And we also wanted to identify the treatment targets. So we conducted this prospective study that followed dyads of patients and caregivers from the admissions to 3 and 6 months later. And we found that the resiliency factors of mindfulness and coping are important predictors of emotional distress. And we also found that patient and caregiver factors are interrelated, such that my emotional distress as a patient impacts my care partner's emotional distress over time and vice versa. So this really suggested to us that a dyadic intervention where we work with patients and caregivers together may be the most efficient way to support patients and caregivers in the ICU. Um, Based on this information, as well as some theoretical models that I'll talk about in a minute, we developed our early conceptual model, which shows that our intervention, and again, we sort of landed on the number of sessions and all these details later, but our intervention components would engage individual resiliency skills, so would lead to improvement in mindfulness, coping, and social support, as well as interpersonal resilience factors. So things like positive dyadic interactions, as well as positive interpersonal communication and support. And as a result, we would see improvement in individual, patient, and caregiver anxiety, depression, and PTSD, as well as dyadic emotional distress. And down the line, we would hope to also see improvement in patient and caregiver quality of life, as well as dyadic quality of life. So, what were some of our findings? So we found support for a dyadic intervention that is delivered early to at-risk dyads who screening for emotional distress. We had support for our mechanistic targets of mindfulness, coping, and dyadic interpersonal support. We also developed and built an infrastructure within the Neuro ICU. And we identify theoretical frameworks that inform our intervention. So we use the response shift framework of adaptation to acute illness, which really specifies that when you're faced with an acute illness, you have to shift your priorities and goals. We use resiliency frameworks, and then we use the dyadic stress and coping model, which really shows that when couples or dyads appraise stress in the same way and approach coping with stress as a team, they do much better than if they cope individually. So what were the intervention development goals? So these were based on the NIH stage model. So we wanted to have an intervention that would be feasible. So people would sign up, that would be credible, that, when we describe it to dyads, they'd say, yes, this makes sense. I want to participate. It would be acceptable. So, people would finish it. They wouldn't drop out. It would be tailored to address the concerns of the specific population. Of course, it will be efficacious. It will be related to improvement in outcomes, hopefully durable. Improvements would maintain over time, effective, and scalable. That long term, we would be able to take this and implement it in multiple settings. So once we completed stage 0, we moved to stakeholder interviews. So we conducted qualitative interviews with patients as well as caregivers. So we talked to dyads together. We also, once we analyzed that data, we conducted focus groups with nurses. So we actually presented the data to nurses and saying, hey, this doesn't make sense to you. What have we missed? Whoops. Sorry about that. I think I pressed on something and missed the, okay, we are back. No, we're not back. Okay. Um, let's see. Continue to share. Sorry about that.
No problem at all.
Okay. Okay. Are we back? We're back. Yay. Okay. So qualitative interviews with that, focus groups with nurses, and we took this information and talked to leadership, get their thoughts as well. And these were the sort of the common themes that we used to finalize our intervention. So there was a lot of anxiety related to uncertainty of the prognosis. There was a lot of fear of future medical events. There were a lot of negative emotions, particularly for caregivers, but also for the patients. A lot of worry, a lot of guilt. And there was a lot of challenges with role changes. So particularly, if the patient, for example, was a woman who was the sort of caretaker for the family, now switching to being a patient was really, really hard. If you're sort of thinking of more of a traditional family context, and similar for the husband, finally the first time they had to take care, switch into this caregiving role was really, really hard. So these were things that we needed to address as part of the intervention. So we also landed on an intervention format that would be hybrid, so that we would start at bedside. If you think about it, we were really um, working with dyads that were going through a traumatic event, sort of being in the ICU. And after discharge, because discharge is very rapid, we wanted to address transition and we focused on switching to live video intervention. So again, helping deliver interventions from hospitalization through discharge. I have some quotes here. I'm not going to go, over them in detail, but you see here just the worry, I feel paralyzed. I can't sleep. That was a caregiver. I'm the one who takes care of everyone. Who's going to be able to take care of him? What if he can't? And then just the trauma there. I look at him hooked up to all those tubes. Will he come back? Is still there. So just sort of a lot of trauma, intense anxiety, from our dyads. Um, okay, so this is our intervention. As I mentioned, it's tailored. So it has two general sessions that are delivered at bedside in a Neuro ICU. And then we have 5 sessions, and out of those 5 sessions, clinicians use 4 um, based on the the dyad's presentation. We didn't invent any skills. These were evidence-based skills that we took from dialectical behavioral therapy as well as mindfulness-based treatments. We had some cognitive skills that were introduced later on in the sessions. So we had to be really sensitive, for this patients have an acute brain injury. And so cognition is pretty tricky early, in the hospitalization. And we also developed a web platform that we downloaded as a simple app on people's phones, as a way for them to practice skills. And again, the skills that we had were very simple exercises, even something like deep breathing that the patients in particular, they could use in the middle of the night, for example, if they were having panic or anxiety. So these are the sessions that you can see here. And we're really, really excited. Our sort of patient and clinician manuals have just been published by Oxford Press. So this is actually, available now, for, clinicians to use in ICUs. Um, okay, so moving on to the next phase of work. So we had some funding from the American Heart Association. So we piloted our intervention with 20 dyads. Again, this sort of speaks a little bit to kind of doing the work that sometimes it is dictated by your funders. So, we wanted to do this work for all newcomers in the ICU, but we really, because our funding was stroke, AHA, we initially focused on stroke. And that actually helped in a way, and I'll talk about that in a little bit later. So again, this was feasibility work. So we used primarily a feasibility of recruitment. 65% of those eligible enrolled, not as high as we would have wanted it. So we knew that we needed to do some work here. Acceptability was pretty high. People completed post-test even as well as 3 months follow-up, which was great. People found the intervention credible. Satisfaction was also high. So generally pretty encouraging. You could see some results here. Again, encouraging. We weren't powered for this, so we can't really, we only had 20 dyads. We can't really talk much about it. So we randomized dyads, I should say, to the Recovering Together intervention as well as a minimally enhanced usual care control. So those in this minimally enhanced usual care control, they would get a pamphlet. So generally pretty encouraging results, primarily around the sort of feasibility. Um, I thought that I'd share, I think we have time. I'd share our recruitment video that we developed based on, information from this first pilot. Can you hear? Oh, you can hear?
We can't
Okay.
hear.
Okay.
We were given.
Okay.
There we go.
Then I will skip it, but
We could just hear it just then. If you try one more time.
To be part of the patient recovery program
You can-
while I was recovering at the Mass General ICU and we are glad that we decided to take advantage of the opportunity.
There were 2 sessions at the hospital, then additional 4 sessions after we got home. We like having the 2 sessions at the hospital because they help explain what we can expect from this recovery program and allowed us to meet a therapist face to face.
I benefited from the sessions in ICU by using some of the relaxation techniques. When I got released from the hospital to home, having regular scheduled sessions over several weeks was great. As patient and caregiver, the regular sessions gave us a way to communicate our expectations, feelings, and anxieties about my recovery through talking in the sessions and by doing some of the exercises recommended by the program.
I like filling out the written questionnaire at the hospital. It helped bring up some perspective that I may not have thought of as part of the recovery of my husband and my role as a caregiver. I like that there was no drugs or travel involved.
We participated in this program because doctors can sit there and they can tell you, the different things that put you at higher risk for having a stroke, but you never can really prepare for when it's going to happen. I think that the program was extremely helpful to my husband and I. My husband was having panic attacks, just thinking about, is it going to happen again? It's really helpful to participate in a program that teaches you skills to reduce that stress. We really feel like the skills that we learned really helped us in the recovery process. Recovery is only going to get so far if you can't take care of yourself as a caregiver, but then also take care of yourself as a survivor.
Yeah. So we didn't tell dyads anything. We basically said, hey, do you want to participate? We got the consent. We got this through the IRB. So they just basically said whatever they wanted. And this has been really, really helpful in recruitment for the second study, which I'm going to talk about right now. So our second trial was a stage 1B pilot RCT. We got an R21 from the National Institute of Nursing Research. I would discourage anyone to apply for an R21. I think we applied 4 times, so just so hard to get. But anyway, we just got this funding and we were able to do this work. We made some modifications to our recruitment to increase our feasibility. So we got the nurses very involved. And nurses did warm handoffs to us. So they actually introduced the study and introduced our team. And that really boosted our feasibility of recruitment to 76%. I should also say that with this funding, we were able to do this work in all patients in the unit, regardless of their acute brain injury. So moved away from just stroke. So we had great feasibility of randomization. Patients were randomized now to recovering together or to an attention placebo control. So we chose a very rigorous high-level control where people were getting the same number of sessions, the same length of session, except those in the control condition were getting just education, while those in the recovering together were getting some education and skills as well. Fidelity again was really good. Satisfaction was high. Credibility, expectancy, just everything was much higher this time. And it really speaks to, the importance of the early stage work. That's so hard to do and so poorly funded, unfortunately, to really get you to a point where, you remove as much of the noise that can confound your future work. So again, even though we weren't fully powered, we were able to run some between group analysis, which were very, very, very strong. So you can see here that we found significant improvement for both patients and caregivers in depression, anxiety, and post-traumatic stress symptoms for those in the intervention versus control, and this maintained over time. So effect sizes were very, very large. There was clear statistically significant difference. So we were really, really thrilled. And this was also corroborated from, just qualitative feedback from the patients and the caregivers as well. And also very important, the nurses really, really loved this study. And in fact, we are finishing up the effectiveness trial right now, and you know, all the other studies on the unit are, kind of mad at us because like nurses want to refer only to us and not to them. But we're sort of working through that. So this is just sort of the picture of recovering together, all the sort of changes and iterations that we made, and all the feedback that we incorporated up to where we are now, which is we are finishing up an R01 for an efficacy effectiveness trial that's basically built on the pilot that I presented earlier. Here we wanted to see, can we replicate the results of the pilot in a fully powered RCT? Can we enroll a diverse sample? Again, at MGH, we're primarily white. However, we're really prioritizing approaching every single dyad that's from an underserved background. Are there any differences in improvement in emotional distress by clinical and demographic variables? Our improvement in outcome explained by improvement in our treatment targets. In our pilot work, we didn't look at dyadic improvement. We only looked at individual improvement, had to do with the sample size. But now we're going to look to see, if the patient improves, is the caregiver also improving within the same dyad? We're asking people to practice skills, but we want to see, do those make a difference or not? And are improvements sustained over time? So our protocol paper is published, and we have 5 more dyads to enroll. So we are at 197 right now, which is very, very exciting. This is the team, again, many, many people working on the team. The funding for this work goes over and above the funding for the R01. I'm lucky that I, run an internship in clinical psychology. So I made a rotation for the clinical psychology fellows, kind of make it a win-win. We also have practicum students that are trained and have, sort of very rigorous training materials, but it's a very dyadic work. I think both Elizabeths are doing, dyadic work. It's very, very hard. You have to absolutely love it. And so you really need a lot of resources. So our referrals came from nurses, but then also we developed relationship with social work. We really worked together, as well as PT, OT, speech, participated in daily rounds and huddles. We also started doing bedside consults to the dyads who are not eligible. So a lot of the times dyads were sad that they weren't eligible. They really sort of, even though they weren't screening in, they sort of felt like they needed support. And so we, developed this consult team. And then, we had our clinical fellows engaged both in clinical care as well as research. So some special considerations in the Neuro ICU. I think a lot of the times in intervention development, we talk about fidelity, and fidelity is so, so, so important. However, there's something called flexibility within fidelity, right? So really, something that's really, really important is to really understand what are the active ingredients of your intervention, things that you absolutely have to deliver because they are directly impacting your outcomes. And what are the other things that you might be able to change? So where can you be flexible? In the Neuro ICU, there are additional considerations. So patients may be in pain, they may be asleep, they may be confused. So you can't just say, well, my session is at 11 and, that's it. If they're not able to participate, we're done, right? So for this trial, we had a clinician assigned every single day of the week in the Neuro ICU. And so they would have to, a lot of the times, kind of go back and forth and catch the dyad at a time where the patient was able to participate. Emergency medical care takes priority, right? So these are people who are so close to death. So, if there's a procedure that they have to do, like that's really important, and we need to step aside to, be able to have that procedure happen. We also had briefer sessions in the ICU. So we never stayed more than 30 minutes in the ICU with a dyad. But after discharge, we were able to have the sessions go up to 50 minutes because the patient, was doing so much better and recovering at home. Very important to have clear and simple communication and skills. I think a lot of the times, particularly in psychology, there is, there's a lot of jargon that we're using. So again, very simple language, teaching and reteaching skills. So recovering together is designed such that we have the core skills are delivered in the first 2 sessions, and then we build on those and make them apply to various scenarios over time. And we also develop the symbols that represent the skills to try to help our dyads. So really, we have a vision for biopsychosocial care in the Neuro ICU. So we really believe that all patients should get some kind of mindfulness skills at bedside. So this is stressful. You may not screen in for emotional distress, but you're going to be activated. And so getting some kind of, mindfulness skills at bedside will be important. For caregivers, having, recommending apps. There are a lot of really good apps out there just as a resource, for them to use as they're kind of sitting around or meeting with patients. Sometimes, patients and caregivers together can say, okay, let's just like take this mindfulness exercise and do it together. When dads are at risk, so they screen in for emotional distress, that they could go through recovering together if the patient is cognitively able to participate. There are also at-risk dyads where the patient has permanent cognitive impairment, and so the patient would never be able to participate, but we could have caregiver-only interventions. So this need to be developed, and in fact, one of my mentees, Alex Prosciutti, just got an R1 to adapt recovering together and and test an intervention called Coma F that has recovering together skills, and then conduct an efficacy trial just in caregivers. There are also caregivers who lose their patient, and grief is a huge problem. So we need to develop something in this space as well. Nurses are very, very stressed. We try to do a mindfulness program. They just don't have time to just come in. I think, I think a lot about all these wellness programs that we develop for stress management, and no one has time for them. They ended up being more stressful. So we have to think about, something that's going to be feasible in this context. And also a training program for, psychology residents, medical residents, social work, and nursing students. How can we sort of allow for this, cross-pollination of knowledge over time? So that's the vision. We're getting close, but there's still a lot of work to do. I mentioned I want to talk a little bit about some of the interventions that have been developed after recovering together. So I mentioned Alex Prosciutti alongside David Huang, who was UNC. They did some qualitative work, developed this Coma F program, conducted an open pilot, and now they're actually conducting an R1 of this intervention for caregivers of patients where the patient is comatose or has cognitive impairment and is not able to participate in a dyadic intervention. Mira Reichman, who was one of my CRCs and now is getting her PhD in clinical psychology. So she is really interested in interventions that are delivered by peers. So she has an F31 right now where she's really thinking about, what can we retain from recovering together that is could be delivered by caregivers who now are, recovered, and they actually want to help other caregivers as well. Alex also has a K23 where he is adapting recovering together for cardiac arrest dyads. So similar, but also a little bit different. I also want to talk a little bit about this idea of integration of clinical research and training, which is really something that we have tried to do from the beginning. And there's a paper that we published in 2022 that really this is a table that I got from that paper that really sort of kind of shows the progression and really shows up sort of where we want to go. And again, we started with more sort of a clinical work, really trying to understand what was going on in the Neuro ICU and what else we needed to do. Then we moved into developing a novel behavioral health service for patients and caregivers with some support from the unit for psychologists. We started developing our research, our quantitative and qualitative studies, integrating trainees, developed RT, and then we really sort of continued with this training, feasibility testing, and effectiveness efficacy trial in parallel with the clinical service, as well as training and really helping primarily clinical psychologists, grow into getting their own grant funding, getting clinical skills, as well as career development. So back to Laura and William. What we did with them, we normalized the stress. We used emotional regulation skills, so dialectics. They worked really, really well on this population. So sort of normalizing that you can have these multiple feelings that are contradictory all at the same time. Talked about mindfulness, but again, very sort of DBT-like. Observe what you're feeling, describe it, and act with awareness. Lots on communication, moving from I to we language, being able to sort of, talk about concerns, talk about feelings, talk about goals. And then we challenge core beliefs. William didn't want to be a burden, help him sort of work through that. And Laura wanted to be stoic, talked a little bit about the value of that. And also we talked about adherence to care and self-care as really important components. So William had another stroke and unfortunately died at the end of the program before we gave him the post-test. Laura completed a post-test and the 3 months follow-up. He was obviously depressed and anxious, and her scores on PTSD were pretty high at post-test, but they went down after the 3 months. This is what she said. Even though her partner died, the program was the best part of the ICU experience. It brought me closer to William. The time and conversations we shared helped me and my family get through this terrible loss. So even though she lost her partner, what she shared was that this was really the first time where William was open about his anxiety, and they really were able to have some meaningful conversations, both with the two of them as well as the extended family. So we've talked about the research in Neuro ICU, recovering together, and adaptations of recovering together. So in the last few minutes, I want to talk about moving this work from the Neuro ICU to outpatient neurological illness. And so we developed this transdiagnostic framework that allows adaptations of recovering together to other outpatient neurological populations. So here it's important to account for contextual factors, so things like the DAD background, illness-related factors, the external resources available, allow for this interdependence between patient and caregivers in terms of both also individual appraisal, but as well as dyadic appraisal, and thinking about how the symptom progression and transition points. When, for example, someone with dementia has a worsening of symptoms, how this may impact the dyad's adjustment to the diagnosis. So in a Neuro ICU, we had an acute illness and then recovery for most people, and then sort of kind of a stable transition, versus in the context of neurodegenerative illness, so MS, ALS, or dementia, you're going to have some fluctuations in symptoms, as well as, times when there's going to be a clear deterioration. And so, you have to, when you're developing interventions, you have to account on for these factors and really teach dyads how to cope with these deteriorations of symptoms. Sarah Bannon has a K23 where she is adapting recovering together for dementia, so for dads of dementia, patients with dementia, as well as family caregivers. Then Christina Rash is doing this work in ALS. She started with a Kornfeld Award, and now she has a K23 as well, which is really exciting. And then we just got an R01 from the NIA to do this work with Brad Dickerson and Maggie Saimi in dyads of persons with a young, early onset dementia and their caregivers. So we just enrolled 3 dyads so far. So we're very, very early on, but really excited about this work. So just a bit of a summary in the last 2 minutes. So biopsychosocial models of care can be implemented within Neuro ICU. It helps to combine clinical care with research and training. It's really important to consider interventions that are individualized to dyads, patients, caregivers, and nurses. Psychosocial factors in care models are really transdiagnostic across neurological illness. And I think it's really this transdiagnostic model, both for emotional distress as well as the neurological illness. I think it's really important because it really allows core skills that can be delivered to various populations. And then what will take to make biopsychosocial care usual care? I think vision, leadership, and good science, interdisciplinary partnerships, and then culture change at the level of institutions, payers, and the nation. So my last slide is, really sort of this process of kind of research. I think when I started, I thought it's this kind of, I'm getting on my bike and I'm just going to have this smooth road. It's never like that. There's lots of challenges. There's lack of funding. There's lessons learned, there's implementation challenges. And I think, particularly in this really, really challenging times that we're living in these days, I think it's really, really important to be perseverant if you really, really care about the research that you're doing in the population that you're doing. I definitely feel I'm going to stop here. I feel for those of you who are early in your career with research right now. It's never been harder in my experience. But I think the work is definitely worthwhile. And I just realized I only have three minutes. Mistimed a little bit the slides, but I can take a couple of questions, and I can also, you can also email me with any questions.
That was incredible. I am so inspired.
Mhm.
I just want to say thank you so much for being so honest about where your journey began. When I heard you say, and then we didn't have any money, but we still did it. And we talked with this, and I want to open it up for questions. And again, I thank you for being willing to answer questions by email. We'll make sure that we'll send that out. But I thank you for that. Wow. No notes.
Yeah, you have to be scrappy. I think, I know much earlier in my career, I did so much stuff pretty much for free, in the sense that I was like, oh, I love it, I need to do it. And then you sort of realize you can't. And also, if you do it, then that sort of is not a good for your discipline, right? Because you're not taking seriously that, hey, my work is valuable. And a lot of the times departments do have resources, primarily medical departments. You just have to sort of, be able to ask for them. So I appreciate you saying that.
I don't have a question per se. I adore your work, and every time you talk, I feel like I just glow with excitement and enthusiasm. So thank you for being a leader in this field. And you can see your gifts of planning and building in your slides and your projects. It's really inspirational to see how I'm not going to say linear, it's not linear, but how you build and construct. And that's not always easy. So thank you for being a leader in that space.
Oh, thanks so much. And back to you. You're doing really, really cool work. And I can't wait to hear about your AD grant and how things are progressing and all the amazing work that you're doing. Well, definitely feel free to reach out. Those of you who do dementia work, we have a Roybal Center for Diabetic Interventions in Dementia. It's dementia specific, but we also talk a lot about just diabetic methods that apply. Everyone's welcome, and yeah, definitely
I
validate questions.
I'll also I'll follow up with you as well because my mother just went through CAR-T therapy and she developed this thing called ICANS, which is like instant dementia. Like on Tuesday she knew who I was and on Wednesday she didn't. And she's doing much better now. But I would love to have, I mean, and this nursing staff were amazing. I mean, she had it here at U of M. They took incredible care of her. But that I just think that when I think about where my father is now, 9 months out after this, after this treatment, and I just think that I think he would be more willing to engage with the kind of psychotherapy, we don't call it that, right? But I think he'd be more willing to do that in this context than when I sort of am trying to prod him into other types of interventions that would be supportive. So I think I guess a question is, in general, do you feel that men are more willing to heterosexual men are more willing to engage in a dyadic intervention for psychotherapy than in an individual level one? Is that consistent with your experience?
Yeah, I mean, it really depend. I think people end up being more open when things get really, really hard. We use skills training, we don't use psychotherapy. And I'm kind of bothered by that, to be honest with you, because I really believe that if we were to transition medical practices to biopsychosocial care where this was just a normal thing that everyone was offered, I think over time we would get rid of stigma. Um, and so, we're not there yet, but yeah, I mean, I think I think men, I think sometimes women as well are not open or normalized, like, hey, I'm supposed to feel like this. This is like, of course, I went through this, which part of it is true, part of it is not. Sometimes, we've had situations where, the caregiver insisted that the patient participate, and then we just kind of got normalized and people started talking. But yeah, I think it's really tricky with I think the stigma and the way we're also, we still have these sort of gender roles in our society. Yeah. I think there's another question.
Oh, no, sorry. That was just me explaining a little bit
Oh,
more.
yeah.
Me,
I
the
think
me
Prashit, did you have a
but
question?
yeah, go ahead, Prashit, please.
Yeah, so I was just curious. First of all, thank you for presentation. It was really enriching for me because my work is also somewhat related to this. Um, I was just curious to know, can this dyadic intervention be applied to situations where you have like hierarchy, like manager and their subordinate, something like that? And if you haven't done it, but let's say if someone else has done it, and then what was the like what were their findings?
Yeah, so that's really, really interesting. I mean, I think that there are maybe some sort of communication interventions, that let's say are done between let's say a provider and a patient. I think with a sort of kind of manager, right, you've got a bit of a hierarchy here that I think it's, can be tricky. Definitely some elements, I think could be used from this. But I think could be probably a little bit different, in this context. But that's a great idea. If you ever want to do that, let me know.
I mean, yeah, that's what I'm working on. Maybe I'll reach
Oh,
out to
that's
you.
great. Yeah,
Yeah,
absolutely. Reach out.
yeah, yeah.
Chris.
All right. Well, thank you. That was a fast hour, but that was so incredible. Thank you so much for your time. Thank you all for being here to continue your learning with us and connecting through other cohorts. It is always an absolute pleasure to see you all. Please don't be a stranger. I love hearing from you and just kind of checking out how things are going. So, Anna Maria, thank you again so much.
Thank you all for having me.
Yes.
Have a good afternoon. Okay,
Thank you,
bye.
everybody. All right. Have a good one.
Bye.